Hi, my name is Dr. Sara Rodgers. I'm with Idaho Naturopathic Medicine, and I'm here today gratefully with Dr. Jeremy Crowfoot. He is a PharmD and works with the St. Alphonsus Regional Medical Center in the Treasure Valley of Idaho. So, Dr. Jeremy, thank you so much for being with us today.
Thank you for talking to me. I'm
Yeah,
excited.
Yeah, so today we're going to talk about insomnia, sleep, and specifically sleep meds because a lot of people are on those. And I recently heard you talk about this at an event for brain health that was promoted by the Treasure Valley YMCA. It was a great symposium, and when I heard you speak, we talked about a lot of drugs there in brain health, but one of the things that you said was a lot of sleep meds can actually cause cognitive decline. So I really was excited to talk to you about that and was wondering, first off, you're welcome to tell me about what you do and who you work for.
Okay. So I am a pharmacist who works in the clinic. And so the clinic that I specifically work in is the St. Alphonsus Geriatrics Clinic in Boise. And kind of an outgrowth of this clinic, and I'm part of it as well, is our memory center. So a majority, I would say probably close to 75% of people that I meet with, number one, they tend to be older, and more than 75% of them have concerns for memory or just have dementia, a diagnosis of dementia. And so my job is not necessarily to find what drugs they should be on, it's to identify what drugs could be causing more problems and making suggestions to try and get to a safer regimen.
That is exciting. And you work with the doctors and you're a team, right?
Yeah, so each person that comes into our clinic, they will meet with either a physician or a nurse practitioner, and they will also meet with a pharmacist and a social worker. So we try and look at all different aspects of the person's life, from medicines to their living environments to their physical health, and trying to address all of those because we know that every one of those is impacted by especially dementia. We also have a special focus on caregiving. And so we spend a lot of time with caregivers because in setting of dementia, people do better when caregivers are supported. There was one study that showed, actually every study that's been done so far, but you can't really patent it, is caregiving provides much better benefit and outcomes than any medicine we've come across yet for in the setting of dementia.
Right, right.
And so supporting the caregivers provides best outcomes for people.
That sounds very exciting. And your whole approach is very naturopathic. So it's very holistic, and that's what naturopaths do. We look at the whole person.
Yes.
It's very exciting that there's a center that's looking at the whole person, especially and including the people in those people's lives. That's very exciting. I'm so excited that something like that is happening within our community.
I don't know anybody else that has a job, especially a pharmacist like mine, and I've been very happy. I've been here for 9 years since it started, and it's been a wonderful job for me. So,
That's wonderful. All right, well, let's switch over to something not so wonderful called cognitive decline
yes.
and talk about sleep med. So there's a variety of sleep med classifications from benzodiazepines to other drugs. You're the expert on that. I don't prescribe these things very often, if at all. So let's just give it to you.
Okay. So you're right. There are a lot of different medications that fall underneath the whole sleep category. Everything from older medications like benzodiazepines to newer medications like Belsomra, repurposed antidepressants like trazodone or mirtazapine can cause sleep. There's blood pressure medicines like clonidine that cause people to get sleepy. There's antihistamines like Benadryl, diphenhydramine. That's what makes up the PM component of most, like Tylenol PM, Advil PM, things like that. There's a lot of different medications that make people sleepy and have been repurposed for sleep. And the general consensus, I mean, I don't want to take this, people to take this and be like, this applies to all situations everywhere all the time. But by and large, you can say all medications that induce sleep impact cognition poorly. And what I mean by that is if you think about the broad way that a sleep medication works, it makes a person sleepy. It makes it so that your cognition does not work as well. It makes it so that you are able to shut down your brain. Now, as you get older, you're not going to metabolize drugs the way you once did. And these effects, I mean, even younger people have hangover effects from like medications like diphenhydramine, like the Tylenol PM. As you get older, it gets worse and worse. And you will talk to a lot of different people who have a hangover effect the next morning. One of my favorite stories was there was a woman who was taking Ambien, probably the most common prescribed sleep medication, very potent medication. She was taking Ambien, had taken it for years and years and years, and I encouraged her to go to a lower dose. She was not happy with me. What we suggested was try cutting the dose in half, and you could take 1/2 tablet when you go to bed. And if you still need the other half tablet after an hour, you can still take the other half. You still have it available. And I suggested not just that you might not need it, the full tablet, but that I try and encourage them to identify benefits. Like you might not have and what I refer to as a hangover effect. She got extremely upset with me and said, I've never had a drink in my life. I don't even know what a hangover would be. And she let me have it. And I'm like, I apologize. It's just a term. But please try it. She reluctantly tried it. We saw her a couple weeks later because we saw her husband. And so she came in too. And she said, before we get started, I just want to say I cut it in half and I was hungover. I was so clouded and I didn't even realize it. And so I think what happens is over time, people get used to the effects from these medications and they don't even realize how they're kind of in a hole that they can't get out of.
Right.
But it worked quite well for her. So that was kind of an exciting story there.
That is, I hadn't even thought about the fact that the drugs are meant to make you sleepy so it reduces your brain activity versus thinking about a healthy, we go through these stages of sleep where we need to get into a deep sleep where we have regeneration of our brain and other parts of our body. And then we have the REM sleep, which is a little more active. And that if you actually reduce your brain activity, you might not be able to actually get through those sleep cycles really well.
Yeah. And no medication for sleep has ever shown to improve the REM cycle. Wow. In fact, they mostly distort the REM cycle. The only caveat to that is if you have true REM sleep disorder, now I'm going to blank on the name. It's a benzodiazepine. I believe it's clonazepam, but I think that it's actually a different one in that group.
I won't hold you to it.
It's the only one that's been shown, and this is a very selective group of people who have a very specific disorder in their REM sleep cycle, and it can help improve their sleep. But every other one, whether it's an over-the-counter thing or if it's a lot of people take alcohol to make them sleepy to go to bed at night, or if it's Ambien or Belsomra, none of them have ever shown to actually improve the REM sleep cycle and can actually distort it further. Although you're sleeping, you're not getting the restorative sleep that is recommended.
Right. I was just in preparation for this. I was reading a little bit about how alcohol affects our sleep because I know when I've stopped drinking wine since last year, which is a really good thing for me. And I had some over the holidays and I woke up and I was like, I'm not hungover, but I don't feel that great. And I've been having really great sleep without alcohol, without that glass of wine with my dinner. And it's interesting because alcohol will make you sleepy. So you think you can get to sleep, but it interrupts how you get into those sleep cycles. And from a naturopathic point of view, we talk about it as liver activation and that it's making your liver work more. And so you're going to have those enzymes work more and it can cause you to wake up mostly around 3 p.m. It's a classic time that people wake up from having to deal with sort of metabolism stuff.
Okay.
So that's just really interesting that none of them are targeting actually getting the sleep stages to be a healthy way, and that the deep sleep precipitates the REM sleep, and that when you go through the sleep cycles, you have less deep sleep through the night and more REM sleep through the night as you get through the night. So that's really interesting. Is there a drug that you really think is one of the worst that you've seen? And I know everybody is different. Everybody metabolizes these different, which is why people try different sleep meds to find the one that works for them. But if you found one that's not the best.
I have different So I have worst in different categories. How about that?
Okay.
So worst of the worst are the ones that affect the GABA receptors. And
Mm.
part of that is because our brain will adapt our GABA receptors to need more and more. So these GABA stimulating medications are going to be things like benzodiazepines, Valium, Ativan, Klonopin, things like that. But also Ambien, Lunesta, Sonata, they stimulate the GABA-1 receptor. And so they can also affect that kind of sleep. These medications, they do not metabolize as well. They don't leave the body quite as fast as we would like them to. And so this is where people get into car accidents the next morning, fall downstairs, different things like that. In fact, in 2011, no medication put people over age of 65 in the hospital more than Ambien that year. So
Oh,
it's
wow.
just it's something that we just don't take seriously because I think we're very worried about sleep. We want to help people with sleep, and so these medications are just easy to prescribe. But things that affect GABA are the worst.
It's interesting. So we should explain what GABA is. So GABA is a neurotransmitter, and
Hmm.
it is a very common neurotransmitter. So people that
Yes.
have, so I do some genetic analysis, and when people have a slight change in their ability to make the GABA receptor or make GABA, then
Hmm.
they're always going to be on that anxiety spectrum because
Yep.
they can't make it really well. And so these medications target that receptor and help promote potentially a GABA effect. But what you're saying is they
Yes.
don't work really well.
Right. So GABA and the GABA receptors in the brain, what they do is when they're stimulated, they make the cells less likely to respond to the next stimulus. Does that make sense?
Yeah.
So our cells are designed to respond to stimulus, but when the GABA receptor is stimulated, it's like you increase the speed bump. You have to have a much bigger stimulus now to try and make them aware. And so other things that stimulate GABA are alcohol is a common one that stimulates GABA. And then there's the benzos, and there's the ambiens, and then there's theanine is one that actually
Mhm.
will stimulate GABA also, but I don't have a problem with theanine. I actually think that that's a great one
Well, I
for
always
people
thought
to
of
try
it
that's
as
natural.
a GABA agonist. An agonist means that it's something that helps promote the receptor, right?
Right. So it will stimulate the receptor, but it's not the other ones. So, like Ambien, it also stimulates the receptor, but it binds to it very tightly. And so, what happens in the body is after it gets stimulated, your body will start to adapt to it and will start to produce more receptors saying, oh, we need more of these now. And so you need more medication to get a bigger and bigger effect. Theanine doesn't seem to do that to the same extent, but it also stimulates the GABA receptor to cause a calming effect, but it doesn't seem to cause this increased dose need down the road. Does that kind
Well,
of make sense?
yeah, that's sort of why people get addicted to these medications, and it's so hard to get
Mm-hmm.
them off of it.
Yep, and that's
Because,
part of the reason. So, of all the medications that are, that people get a hold of that are illicit, like marijuana, cocaine, opioids, alcohol, the only one that will actually kill you in withdrawal is alcohol. And the reason being is the fact that for anyone who's drank alcohol, you get a big effect when you first try it. And then you need more, and then you need more, and then you need more. And so if you get to the point where you're drinking it all the time, you're drinking it more and more, but you're also changing the receptors in the brain. And so what ends up happening is if you abruptly stop alcohol, and this is why people have to go into detox facilities to actually come off alcohol, is if you abruptly stop it, now all these cells can be stimulated just immediately because it doesn't have this thing that's slowing it down, the GABA that should be there.
right,
And so then they end up having heart attacks, seizures, different things like that because they're just so overstimulated.
right. I know
So,
it's
but that's kind of what happens with all these other medications to a lesser extent on the brain. So,
right. That is so interesting. And from a naturopathic perspective, we are always trying to find the cause of the problem. And
mm-hmm.
so with sleep, whether it is they're, we just had some people over for dinner and they were like drinking coffee, not decaf at night. I'm like, I can't go to sleep. or alcohol, which will cause sleeplessness with initial drowsiness, or eating sugar at night. Like dessert should not be eaten at night, right? Because
Yep.
it'll create an effect where you can end up with low blood sugar, and then you get a rise in your stimulating hormone called cortisol, which will then cause an alertness. So there's all these different reasons why people might not be able to sleep. And it could also be that they're genetically just have no GABA receptors or not able to make GABA, or they might have some nutritional deficiencies that might not make GABA.
Mhm.
So it's really interesting that there are potentially other ways that people can get to sleep without these drugs. But these drugs are really a lot of things that only they're offered by the
Yeah.
greater medical community. And it would be great if they sort of understood more about their lifestyle and how it can affect their sleep habits.
Right. So one thing that I encourage providers to do on a regular basis is ask more questions. If a person is struggling with sleep, sleep is actually a very natural thing to occur. And I don't want people who struggle with it to think that I'm treating it flippantly.
Right.
But there is something wrong, and we need to try and figure out what that one thing is. I have seen people who, because they have to get up at night to urinate, they're on a sleep medication. That's not ideal. Like, we should be helping with the urination, come up with new solutions there rather than giving them a sleep medication. I have talked with people, they'll tell me that they get up in the middle of the night, and usually it's people with dementia and their caregivers are really upset. Well, what I find out is when you ask more questions, right now in the Treasure Valley, it's getting dark at like 5:30 p.m. A lot of people who have dementia take their cues from the outside light.
Mhm.
If you're going to bed at 6 or 7 and you wake up at 2 in the morning, you've already been in bed for 7 to 8 hours. Let's not give them a medication to zonk them out more. We need to try and help the caregivers find other ways to keep the person engaged until they're ready to go to bed and be in bed for 8 hours. And that will keep them from getting up in the middle of the night.
Right,
Other
right.
things are making sure you get up and do things throughout the day. If you don't have physical activity or some sort of stimulation throughout the day, the worst of all is if you're sitting in a chair watching TV all day,
Mhm.
you're not going to be tired enough to go to bed. Another thing that I talk to people about, and I hope no one takes this insultingly because I really want it to relate to everyone, but a lot of people have had children. And you can think about what it was like when you had your own kids. And it was, if you get home at like 5 p.m. and you see your 3 year old asleep on the couch, you're like, oh no, it's going to be a late one tonight. So, same thing applies at any age, but especially as you're older. Like, if you're taking naps during the day, you're going to have a hard time going to sleep at night. And it just kind of goes on and on. Another thing that we also encourage is whether you want to acknowledge it or not, there's everyone has a sleep ritual, like a ritual as they're getting ready for bed. And usually it's you brush your teeth, you get on your pajamas, you maybe read a book, different things like that. If you relate that to kids again, when I would be tucking my youngest one into bed, we're reading a story, we're trying to keep things calm, we're trying to keep it relaxed. And if an older one comes in doing cartwheels into the bedroom, you're like, oh my gosh, now we have to restart everything. People need to realize who those cartwheeling kids are that are disturbing their ritual in the evening. It could be, I mean, now and anymore, it's the news. So we encourage a lot of people just to stop watching the news after like 5 or 7 p.m.
I've been encouraging my patients not to listen to the news, period.
Yeah.
Yeah.
I mean, you could, if you
They're
want to in the
really,
morning, great, but don't do it at bedtime.
yeah.
But it could be a movie. It could be just being on your phone, looking at scrolling through Facebook or something like that. There's a lot of different things that stimulate our brain, and we need to be aware of that and how it could be disturbing our sleep at night. Other things that people, like someone the other day said, well, what about taking a bath before bed? I'm like, if that helps you, that's wonderful. If you want sleepy time tea, if you want warm milk, try all of those before we're going to medicines because the medicines are not going to improve things long term.
Right, right. And also, one of the things that's happened in the last 20 years is that there's all these screens. And I know
Yep,
that people have had televisions in their bedrooms for years, but I think a bedroom should be there for sleeping. And that,
yep,
in the summer, you have blackout curtains, and we're still using our blackout curtains. We
yeah.
just keep the room really dark. And unfortunately, I wake up by myself at 6:30, regardless of this. But the blackout curtains, you only have mechanical items in your room. You don't have even an electric clock. You make sure that your bed is not next to, on the other side of the wall, is any sort of big appliance that might be causing some EMF issues, or make sure your bed is not next to any electrical panels. You take all the screens out, and that if you have to get up because you're awake and you need a little break from lying there for a while being asleep, you get up and you read a book, or you get
Yep.
up and you listen to music, or you get up and you do something that doesn't stimulate your brain, but
Yep.
you do something that actually takes you out of your brain, away from any sort of repetitive thoughts or worries of the day. And then you try to go back to sleep in about 20 minutes and see what happens.
And I
But
really like the getting up and going to like a chair,
yeah,
because reading book in a bed teaches your brain, oh, I read here in bed. But getting
exactly.
in a chair and then moving back helps reset everything.
Exactly, exactly. So, what is your general advice? And I know that this is not for any one person, but your general advice if somebody has decided that after listening to this, they want to try to get off their medication. Is there a
Yeah.
specific amount of time between reducing by what dose? Do you
Yeah.
have a recommendation?
Right. Okay. So, first of all, if people want to know more about this or see a very eloquent visual perspective of this, I recommend people look at mysleepwell.ca.
Okay.
This is a Canadian website. That's why it's .ca. I think it's out of New Brunswick or something like that. It is brilliant. Like the step-by-step approaches, the way it describes how medications can affect the brain, why natural sleep is more important. It I can't say it better than the way they show it in their pictures and stuff like that. So that's a great place to start.
Okay.
Next thing is I would make your doctor aware. So if it's prescribed by the physician or provider that you have, nurse practitioner, PA, naturopath, I would talk to them and just let them know that you want to reduce the dose. Part of that is because sometimes that affects other medications you're on.
Hmm.
And so, or maybe there's a really good reason why you're on something. And this is just general advice for everyone, but maybe not to a specific individual. So make them aware. Then the next steps, the way that we do it, it depends on the medication. Any medication that affects the GABA receptors, so this is going to be Ambien, Zolpidem, Zaloplon, Lunesta, and then the benzos, which are like Valium, Ativan, Klonopin, Temazepam. I mean, there's just anything that ends in Pam. These have to be reduced slowly, very slowly. Like it's taking a half a tablet less once a week or twice a week and changing that dose every couple weeks. Like it's a very slow progression and you'll get off the medicine in about 3 months. The idea is that if you come off these medications quickly, that's where the overstimulation occurs. You're much less likely to be successful with your dose reduction then. If it's another medication, if we're talking about trazodone, if we're talking about mirtazapine, if we're talking about over-the-counter things like sleep aids, if it just says sleep aid on the bottle, which probably doxylamine or diphenhydramine, or if it's something PM, those ones what we tell people to do is cut your dose in half. So if you're taking 2 of them, take 1. If you're taking 1, if you can cut it in half, great. Reduce the dose by 1/2 every week. If you're not comfortable with that, you can do it every 2 weeks. And follow that same recommendation I gave to that lady about the Zolpidem. Try cutting it in half. You can take half when you go to bed. You can still take the other half if you need it. And what you'll find is you'll need that second half less and less.
Mm-hmm.
And then if there is a lower dose, so you can more easily cut the tablet in half, great. Otherwise, once you get down to half a tablet of the lowest dose, and you've been on it for a couple weeks, and when you're ready, you can stop it. One more thing I'll say is right now, as we're having this conversation, is December 3rd. Christmas is coming up. We are very unsuccessful with coming off medications around big events because big events, whether it's a family reunion, whether it's Christmas, whether it's some other holiday that you love, 4th of July, something like that, it's like being on a whole nother drug altogether. And that overstimulation can be joyful, it can be happy, but it can also be stressful. And so trying to make these changes around those time if you're in the middle of a change, just take a break for a bit. There's no reason to force it.
Right.
Um, it's just not very successful in those times. Don't be frustrated if you have a hard time reducing the dose around those times.
That is great advice. I appreciate you saying that because, um, and especially like even in January, where people are
Mm-hmm.
trying to recover from everything that happened
Yeah.
in December, is you take a break. You might want to learn more about things, go to the classes, like go to exercise, change your diet. And
Mm-hmm.
then as the light starts coming back, that is the time when
Yep.
you'll have more energy, you'll have more drive, and it'll be easier to do. So I think that
Yeah.
is great advice. Thank you for so much for saying that.
Yeah, you're welcome.
Yeah. Was there anything else you wanted to add before we ended this?
Um, there is one thing. I probably should have said this earlier because it's become a little bit out of sorts here, but there's there's one group of things that I find a lot of people are not aware of, and I think they should be. And it's the fact that medications for sleep, until like the last 10, 15 years, were never tested in women.
This does
Yeah.
not
And
surprise me. This does
so
not surprise me.
So it stems from, remember in the 1960s, you might have read about it or heard about it, the thalidomide issue, right? And the birth defects with kids, and it was never approved in the United States by the FDA, which was, the woman who did that is a genius, and she did a wonderful job protecting people in the United States from that medication. But then they overcorrected, and they said, well, any woman who is of childbearing age, we don't want to run these risks. So they never tested all medications unless it was like estrogen or something specific for women. They never tested it in women.
No,
And that was considered ethically correct in what it should be until about 2010. So the bulk of the sleep medications that we have available to us today were never tested in women. And when they actually went back and looked at the data in the mid 20 teens, they saw that women were at a statistically significant higher risk of having car accidents, falling downstairs, all sorts of other things. And they think what it is part of it is in typical, a little bit smaller body size, but also they don't seem to provide, women seem to produce, they seem to metabolize the drug at a slower rate on average than men. And not a hugely smaller rate, but at enough that they could actually see it in the data that it was causing more side effects in women than in men. So there's that I find is interesting, and people should be aware of that.
Well, there's two things that I have to say about that. Number one is women have more hormones throughout the month that they're having to metabolize. So there might be more using.
Yeah, it's already preoccupied, right?
Right. And then also progesterone is a GABA agonist.
Mm-hmm.
And so I've used it to help sleep in perimenopause and menopausal women. It's really helpful for their sleep because that's when sleeplessness happens in a lot of women.
Yeah.
But the fact is that maybe there's already a potentiation of the GABA receptors, and then you add a GABA agonist on, and then it's just too much.
Here's one more thing that I find interesting.
Oh, you have a lot of great things.
Yeah.
Keep talking.
The studies for sleep medications, so we're talking specifically about the Z hypnotics like Ambien, Lunesta, different things like that. They only tested them over 2-week time period. So
even for the men.
I mean, that's who it was running, was in men, right? It was only tested over a 2-week time period. If you look at the original FDA approval, it was only approved for a max of 14 days. You weren't supposed to go beyond that. What ended up happening was the drug companies were like, hey, we think this is pretty safe. So they did do 6-month studies, but that was not for efficacy. That was just to look at, are we causing more harm if people are on it for 6 months? And so then the FDA said, it looks okay. You can go ahead and we can just do this indefinitely now. So if you actually look at the studies for sleep induction, these medications are actually very good the very first time you take them. Like, they will conk you out, you will go to sleep, if that's what your goal is, right? But their efficacy in continuing with sleep actually wanes after about a week to 2 weeks, which is why you limit it to 2 weeks and you don't go longer than that. And so as their efficacy wanes, what I find is a lot of people, I think the reason why they like the medication so much is, number one, it provided great relief when they first took it. And so they feel kind of an allegiance to it or something like that. And then over time, it actually doesn't work that well anymore. You actually go back to, and the My Sleep Well website actually goes and talks about this kind of stuff. Your body goes back to what its baseline was, but now you're taking this medication, you're still getting the side effects from it, but the sleep induction is no longer there. So another thing is trazodone's become like the default sleep medication that everybody gets. If you look at the studies for trazodone, they're terrible. Like, you do get better sleep in the first week. And by the end of week 2, you're back to like same amount of sleep, hours per night, going like what time you go to sleep as you did in the placebo group. So there's really no difference, but I think it provides such a huge relief initially that people still keep coming back to it and thinking that it's beneficial.
That is fascinating. So we never talk about that dynamic of how the drug works when it's on the package. And it doesn't say like, you should only take this for 2 weeks because after 2 weeks it's not going to work.
Yeah.
They don't say that extra part.
Yeah. No, because that would reduce sales, right? And so
we're not
you don't want to reduce sales.
Monetary parts of that. So what I'm getting from this conversation is, if you are if you're really struggling and you have insomnia and you need to get to sleep right away because you've got something big coming up, these drugs might be helpful for a few days. But you really need to look at the underlying cause of why you're not sleeping, whether it is from stress and that you need to do some mindful meditation or exercise, or make sure you're not napping in the day when you're tired the next day. You need to stay up, get through that fatigue, make sure you're doing good sleep hygiene, keeping that routine at bedtime. Don't let the 11-year-old cartwheel come in. And I love that theme there. And so making sure that, the drugs work, but you should know that they're not going to always work after even a small amount of period, and that we should really figure out what the problems are. And what's really interesting is it could be even like a new mattress. So I do environmental medicine. And so if you're having a lot of VOCs coming out of that mattress, which are volatile organic compounds, the preservatives within the mattress sort of thing, is that'll make sure your liver's working extra hard and it'll affect your brain. So it's even like just knowing those sort of things is really important to understand why somebody's not sleeping.
Yep.
So I'm very excited that you took the time today, Dr. Jeremy, to talk to us about this. This has been fascinating. So thank you.
It's been fun too, right?
Yeah. Yeah. If you want to talk about something else some other time, I'd be happy to do that.
Great.
But I will be posting that website on this video. It'll be within the video. And then also links about Dr. Jeremy, if you're interested in the Memory Center and his work, we can post that as well. So thank you so much. Was there anything else you wanted to say before I stop the recording?
No, I mean, I have a lot of things going through my mind right now, like we could say this or that, but I think we got the good stuff. So yeah.
Okay. All right. Well, thank you so much for your time today.
I appreciate it. Thank you. Have a good day.
You too. Bye-bye.
Bye.